Another infection that was asked in PDCC examination was cytomegalovirus. So, what is CMV? CMV is caused by cytomegalovirus. It is a member of herpes viridae and it is the most common congenital viral infection worldwide. Now, coming to transmission, it occurs whenever there is contact with the infected saliva, urine, or sexual contact. It also occurs transplacentally, hence primary concern in pregnancy is transplacental transmission, and it is teratogenic also. It is released in breast milk also. So both pregnancy and lactation are the risk factor for fetus. Now, coming to maternal features, usually mothers are asymptomatic because viral infection is occurring. So patient can present with flu-like illness like fever, malaise, and lymphadenopathy, and it is often undiagnosed. Now, coming to fetal effects. So can you see here? So these are the lateral ventricles and these are going down, and these ventricles periphery is having certain calcifications. So this is pericentric calcifications seen in cytomegalovirus infection. It is the hallmark of the infection. Now this is the normal head of the baby. Can you see this? The head is reduced and there is this lymphadenopathy. So babies are IUGR, means small for gestational age. So these babies are small for gestational age. There is microcephaly, there is presence of jaundice at birth, hepatosplenomegaly, petechiae, hemolytic anemia, and pneumonia also occurs in these babies. Now, can you see the disc? And there is increased number of vessels around the disc. So this is the retinal image, and this is showing chorioretinitis. And this is also periventricular calcification shown. These are also periventricular calcification, and this is a baby with small head, means microcephaly, which is one of the feature of congenital CMV. Now, coming to classical features, there is periventricular intracranial calcification, which is the hallmark. There is microcephaly, there is SNHL or sensory neural hearing loss, which have also been present in rubella syndrome, and there is chorioretinitis. Other findings includes IUGR, hepatosplenomegaly, thrombocytopenia, blueberry muffin rash. Risk pattern is risk transmission risk increases with gestational age, and as similar to the rubella, severity is highest in the first trimester. Early infection causes more damage and late infection causes more transmission. So for diagnosis, after doing serology of the mother, we can see that there is a presence of IgM, CMV, and when we do, and if IgGs are positive, then we can do additive test to confirm recent or past infection. In fetus, amniotic fluid is tested for CMV DNA, and it is done by 21 weeks, after 21 weeks. Ultrasound findings can also be significant, like ventriculomegaly, mild, moderate, or severe, and calcifications and IUGR. There is no definite treatment for this. Ultimately, universally accepted therapy in pregnancy. CMV hyperimmunoglobulin can be advised, and CMV patient, because ganciclovir is an antiviral, can be given, but it is routinely not recommended in pregnancy. So the mainstay of treatment is counseling and monitoring only. Prevention, there is no vaccine available for CMV. Hygienic precautions like hand washing, especially after contact with children's saliva or urine, avoiding sharing utensils with the toddlers. So intracranial calcification, if periventricular, then it is CMV, and if diffuse calcifications are present, then it is associated with toxoplasmosis. And the most common sequel is hearing loss. And hydrocephalus is also noted in toxoplasmosis. So this is the next infection that we have answered. So there are certain things that I can also add. So the gold standard for the diagnosis of fetal infection is PCR, where the sensitivity is 70 to 99%, and sensitivity is higher because it after it is performed 6 weeks after maternal infection and after 21 weeks of gestation. So this is the point that they have asked. And valganciclovir can be given, but it is not advised in pregnancy at all.